My next guest has been reaping the benefits of this craze somewhat. His company makes oral weight loss drug Contrave. It's been on the market for more than a decade and has a much lower price tag than the injectable drugs. Joining me for more is George Hampton. He is the CEO of Currax. George, welcome.
Hi, Kelly.
How does Currax work?
How does Currax work?
Yeah.
Well, we are an anti-obesity company. We have a product called Contrave.
How does Contrave work?
How does Contrave work?
Yeah.
Contrave works centrally. And so where the GLP-1s work primarily in the gut, Contrave works in the brain, controlling both a person's desire to have a desire to eat and a craving that may come around as a result of a kind of an irrational reason.
What has been the sort of result of people who used it before and after? What typically happens for people on the drug?
Well, in order to receive the indication, you have to help a person drop weight by more than 5%. And so Contrave has that indication. But we have patients that are dropping significantly more than that, depending on the individual patient.
This has been around for, as you said, a decade. And yet the weight loss drug craze has really kicked off in just the last couple of years with these injectables. What do you attribute that to? Well,
I think the new products are exciting, right? The GLP-1s are going to change the scope. Plus, they're being brought to market by two incredible companies, right? These are Eli Lilly and Novo Nordisk, two of the largest in the world. And when Eli Lilly comes to market, they come to market with all the services and patient support and everything else that's necessary really to help develop a market. And yes, we are benefiting from that significantly.
But in other words, do you think these drugs are a step beyond what was previously achievable by medications on the market? Or are people going to start to realize maybe yours or maybe there's others out there that have some benefits as well that are working, and this isn't the weight loss drug pill and craze and whatever of decades past?
Well, this is the latter, right? And so in every chronic disease that we've ever controlled as a society, we've had multiple types of medications in the class. And so right now within anti-obesity, we have GLP-1s. We have my product that is a reward system modulator, and then we have the controlled substances like phentermine. And so we need 5, 6, 7 classes of medication over time to really get control of this chronic disease. It's our #1 epidemic in the U.S. It's 100+ million U.S. adults, and it's affecting 43% of the population.
Do you find, have you been able to run tests to see if it could also treat things like other addictive behaviors and problems like we're finding with some of the GLPs?
We have, and it does. We have a phase 3 ready program that we're negotiating with the FDA right now to take a version of Contrave into clinical trial.
Do you have the same issue as the GLPs where once you stop taking it, evidently the weight comes back and the behaviors return?
Unfortunately, obesity is a chronic disease. And a chronic disease is if you stop the medication, you're going to have the disease come back, whether that's hypertension, high cholesterol, or weight.
Right. But I guess other than that, would you say there are sort of difficult side effects of using these medications, or is the main issue that you just have to keep taking it in order for it to be successful?
We have to keep taking the medication, and not everyone tolerates every medication the same. And so while the GLP-1s are exciting medication, one size does not fit all. And so you need these other classes like Contrave and some of the phentermine products to be able to help patients navigate their own individual disease journey. But you will need to take the medication for your entire life.
Do you agree with those who say there needs to be more scrutiny of big food, so to speak, a lot of the processed foods and restaurant foods, fast foods that are contributing to these outcomes in society?
It's so far outside of anything that I think about on a daily basis. I think the food companies really would want to comment on how that works and what's there. And I know that's a new hot topic.
No, I think people are just saying, look, once it gets to the point, like you said, that it's so widespread and such an issue, do we need to look at root causes and not just treat the symptoms?
I'm glad you said that, because the root cause is that we've not paid for obesity. So you think of every other chronic disease in our history as a society, we've intervened, right? We've paid for hypertension medications. We've paid for type 2 diabetes medications. Obesity we have not paid for, right? It's carved out of Medicare. Right now there's a bill that could be voted on by the end of the year called the Treat and Reduce Obesity Act, which would finally allow CMS to begin covering obesity meds. And we see the result of not intervening in a chronic disease. We went from 10% a few decades ago obese to over 40% obese, and it's not going to stop unless we intervene.
So speaking of the pay for, if we start covering this, it's going to be very expensive for the GLP-1s, at least in the near term, upwards of $1,000. It depends on how exactly the math works out. I don't know how much yours is. That's a big price tag in the short term, even if in the long term it helps to bend the cost curve.
Well, I think there is a big price tag up front. Now, the CBO recently released their estimate, and it was much lower than everyone thought, because there is an offset, right? When you treat a disease like obesity, you're offsetting some of the other collateral damage that's done on the body, heart disease, diabetes, et cetera, right? And so there's an opportunity there to offset some of these costs. We have introduced, what Lilly has also introduced, is a direct program, right? So patients can receive Contrave $99 shipped right to their home, And we put that in place as a bridge to when coverage actually comes into place, because we just can't, as a country, really justify waiting any longer. And so Lilly's done the same thing with our Lilly Direct program.
I think Pfizer and some others have an oral that they're working on. So this space is about to get very crowded.
There's over 70 programs in clinical development.
Wow, 70. Yeah. Okay. So, yeah. Is the outcome of the election next week a swing factor for you one way or the other? I mean, is there a set of policy proposals that you think more favor your company and the adoption and enshrinement of weight loss drugs as part of the modern culture, or no?
Well, I think both parties are equally hard on pharma in their own ways, right, across the board. What I think is really missing here, and I'm not a political strategist by any stretch, but if you have 43% of the population that's overweight, and you have a bill that's right now ready to be voted on and passed, and it doesn't matter whether you're a Democrat or Republican or what your demographic is, and you can get behind passing that bill, it seems like you would be pulling along 43% of the U.S. population with you, saying we're finally going to do what should have been done years ago, and that's cover obesity as a disease.
We'll be watching that legislation closely. I know you will be as well.
For sure.
George, thanks for joining us today.
Thank you.
George Hampton with Currax.